today I will be presenting on introduction to onco-nephrology. So the cancer is a common global problem and the leading cause of the death worldwide. The estimated deaths in the 2018 are almost 9.6 million deaths in the 2018. So cancer is a common and a leading cause of death worldwide. And the estimated deaths due to cancers are almost 9.6 million deaths in 2018. The worldwide cancer cases are projected. So worldwide cancer cases are projected to increase by almost 50% by the year 2030, from 14 million to almost 21 million. And the worldwide cancer deaths are projected to increase by almost 60% by the year 2030. The most common causes of cancer deaths are because of the lung cancers. The second most common is colorectal carcinomas, and the minimal deaths are from the breast carcinomas. So AKI is very common among the cancer patients. So there's one study carried in Denmark population. So among 1.2 million people, there was almost 37,000 incident of cancer patients between 1999 to 2006. And there was almost 17% of risk of 1 year risk of acute kidney injury among these patients, and almost 27% of risk of acute kidney injury after 5 years of the diagnosis of the cancer. And the highest risk was found among the kidney cancer, that is almost 44%. And second most common was the liver cancer, and the third most was the myeloma. So among the cancer patients, the acute kidney injury is very common, maybe due to disease or maybe due to the treatment of the cancer itself. So there's another study in Belgium population, that is Belgian renal insufficiency and anti-cancer medication study. That study has showed this quite association of kidney injury with cancers of prostate, gynecological cancers, breast cancers, lung and colorectal cancers. So kidney disease is very frequent and increasing complication of cancers due to advanced treatments and increased survival rate in the cancer population. And there's bidirectional relationship between cancer and kidney diseases. The sepsis, hypovolemia, and obstruction due to the cancer cells are the most common causes of acute kidney injury, followed by tumor lysis syndrome, hypercalcemia in cancer patients. So the acute kidney injury, chronic kidney disease, um, uh, and cancers are interrelated through paraneoplastic kidney injury due to toxins and nephrotoxins, the radiation or nephrectomy used in kidney cancer, or uremic milieu like chronic kidney disease, end-stage renal disease, or transplant patients. So there are also common exposures that can cause both renal cell cancer and chronic kidney disease, like smoking, hypertension, obesity, toxin exposures, analgesics, hepatitis C, sickle cell disease, diabetes mellitus. These all are the common exposures which may cause chronic kidney disease and acquired cystic diseases. Again, in return, renal cell carcinoma due to loss of renal mass, hyperfiltration, and ischemic time. The cancer-specific risk factors for acute kidney injury in cancer patients are age of the patient, more than 65 years, comorbid conditions like chronic kidney disease, congestive heart failure, maybe due to exposure to anthracyclines or trastuzumab. Then hypovolemia due to chemotherapy-related nausea, vomiting, acute graft versus host disease. Then distance metastasis. Multiple myeloma is again the major risk factor for acute kidney injury in such patients. Liver cancer, then nephrectomy for renal cell carcinoma, and induction chemotherapy for acute lymphoma or leukemia, that may cause increased tumor burden to the patient's kidney, and that may pose risk to the acute kidney injury in such patients. So overall, causes of acute kidney injury in cancer patients may be directly related to the malignancy, like tumor infiltration, nephropathy in multiple myeloma, then hypercalcemia, obstruction, or graft versus uh, host disease, and the direct effects of cancer therapy, causing nephrotoxicity of chemotherapy, radiation damage, and nephrectomy. The other complications of cancer treatment, tumor lysis, cytokine release syndrome, neutropenic sepsis, that may pose patient to acute kidney injury risk. And other factors like volume depletion, contrast exposure, nephrotoxic drugs may cause acute kidney injury in cancer patients. So, the risk of acute kidney injury after cancer diagnosis uh, in the first year is almost 18%, and 27% of risk of AKI in the first 5 years of the diagnosis of the cancer. So, 40% of the critical ill patients with cancer may require kidney replacement therapy. The acute kidney injury is highly prevalent complication in patients with cancer, while risk factors for developing acute kidney injury are similar to those of general population. Patients with cancer may also develop acute kidney injury due to cancer per se or their treatment. The treatment related injury seen with chemotherapy, immunotherapy, with a nephrectomy, with hematopoietic stem cell transplant, or injury due to metabolic complications of cancer like hypercalcemia, tumor lysis syndrome, or injury due to the cancer causing thrombotic microangiopathy or direct infiltration of the cancer cells by in the glomeruli or interstitium, then paraproteinemia or obstructive nephropathy causing intratubular or extrarenal obstruction. So drug toxicity in relation to the nephron, uh, s- uh, there may be different, each part of nephron is affected due to multiple drugs uh, in the cancer treatment, like gemcitabine, doxorubicin, mitomycin, cisplatin drugs, platin drugs or protease inhibitors, like vascular endothelial growth factor inhibitors. They act at vasculature in the glomerulus, and the other drugs like tyrosine kinase inhibitors, EGFR inhibitors, they may also affect the glomeruli. The platin group of the drugs and protease inhibitors, they may also affect the interstitium of the nephron. The cyclophosphamides and BRAF inhibitors, they may act at distal convoluted tubule, and other drugs acting at the collecting ducts like methotrexate and uh, tumor lysis syndrome due to ibrutinib. So tumor lysis syndrome is a constellation of metabolic abnormalities resulting from either spontaneous or chemotherapy-induced tumor cell death. It consists of hyperuricemia, hyperphosphatemia, hypocalcemia, and hyperkalemia. It may lead to acute kidney injury, arrhythmias, or seizures. It is most common oncologic emergency, and it is most commonly described in non-Hodgkin lymphoma, but also uh, may occur in acute lymphocytic and lymphoblastic leukemia, acute myeloid leukemia type 6 and 8, and less commonly in chronic lymphoid leukemia and multiple myeloma. Solid malignancies with large tumor burden. um and metastatic disease in the liver, or small cell carcinoma of lung, germ cell tumors, neuroblastoma, and the breast carcinoma. Other are the other cancers which may complicate with the tumor lysis syndrome. The risk factors for the tumor lysis are mostly increased tumor burden, massive liver mets, bone marrow involvement, stage of cancer, proliferation rate of the carcinoma, cell sensitivity to cytotoxic therapy, age, volume depletion, and pre-existing chronic kidney disease. So tumor lysis syndrome, there are lab diagnosis and clinical diagnosis. So at least 2 hours with at least two criteria within 24 hours of lab diagnosis, that is hyperphosphatemia, phosphorus more than 4.5 mg per deciliter, and potassium more than 6 milliequivalent per liter or 25% increase in the baseline. The corrected calcium less than 7 mg per deciliter, and uric acid of 25% increase from the baseline or more than 8 mg per deciliter. At least it should meet with at least one clinical criteria, including increased creatinine more than 1.5 upper normal limit, or arrhythmias or seizures. The management of tumor lysis syndrome includes aggressive intravenous hydration, maintain high urine flow, medical management of electrolyte abnormalities, uric acid therapies with allopurinol or rasburicase, or hemodialysis for refractory hyperkalemia or symptomatic hypocalcemia. So this is Caro Bishop definition, which I earlier described for the laboratory tumor lysis syndrome and clinical tumor lysis syndrome. So the what happens with the this thing purine metabolism is the adenosine monophosphate are converted to inosine monophosphate, and that is converted to hypoxanthine. This hypoxanthine is converted to xanthine with the help of xanthine oxidase, and the allopurinol is a xanthine oxidase inhibitor, which inhibits production of uric acid uh, and helps in tumor lysis syndrome. The allopurinol is converted to the oxypurinol in vivo form, and it is excreted in urinary uh, uh, in urine. So allopurinol, through its inhibition of xanthine oxidase, limits this de novo formation of uric acid and increases production of oxypurinol. The rasburicase is a recombinant form of xanthine oxidase, which helps to break down the uric acid to a more soluble and radical excreted chemical, allantoin. So, the management of tumor lysis mainly involves the prophylaxis and continuous monitoring of electrolytes, the volume expansion with target of urine output at least 2 ml per kg per hour, with the high dose of intravenous fluid. Urinary alkalinization is not recommended. This allopurinol, as I said, has hypersensitivity, acute hepatitis, and eosinophilia as side effects. But the febuxostat has no hypersensitivity compared to allopurinol, but it is costly. This rasburicase is a recombinant urate oxidase. It should be carefully used in patients with G6PD deficiency, because these patients may develop methemoglobinemia after rasburicase. Renal replacement therapy may be used in severe tumor lysis syndrome in IHD patients with rebound serum hyperkalemia and hyperphosphatemia. So we are moving to electrolyte and acid-base disorders in malignancy. So it may cause malignancy may cause hyponatremia, hypokalemia, hyperkalemia, hypomagnesemia, hypercalcemia, hypophosphatemia, and metabolic acidosis in cancer patients. The common mechanisms for hyponatremia in cancer patients are pseudohyponatremia due to paraproteinemias. This reduced water excretion due to underlying CKD or acute kidney injury. The decreased circulatory volume in cancer patients due to nausea, vomiting, nasogastric suctioning, and diarrhea, hematemesis or hematogasia in gastrointestinal malignancies, or steroid-induced ulcer diseases. This decreased effective circulatory volume leading to hyponatremia uh, maybe due to cirrhosis, congestive heart failure, ascites, or veno-occlusive diseases. Uh, in cancer patients, SIADH is also common. The pathology behind it of is tumor release of antidiuretic hormone in carcinomas like small cell lung carcinoma, head neck cancers, and the chemotherapy drugs like cyclophosphamide, cisplatin, carboplatin, with distinct group of drugs, they may cause SIDH as uh, side effect in these patients. This non-osmotic stimuli for the antidiuretic hormone in these patients because of the pain, nausea, or vomiting. Cisplatin also causes salt wasting and leading to hyponatremia in malignancy. So moving towards hypokalemia. Uh, Hypokalemia may be due to it's pseudohypokalemia because of the phlebotomy error with tight tourniquet, which is cancer distinct, or clonal leukocytosis with leukemias. This redistribution of the potassium into cells by the use of granulocyte macrophage colony stimulating factor or vitamin B12. The blast crisis with leukemias may cause hypokalemia. There's poor intake because of anorexia, nausea, or mucositis, which may lead to hypokalemia. There are extrarenal losses like vomiting, diarrhea from chemotherapy or radiation, enteritis, or renal losses like hypomagnesemia, Fanconi syndrome with chemotherapy. Then hypomagnesemia, the absorption of magnesium from the tubular lumen is via EGFR dependent apical channel, that is transient receptor potential MCs. This pathway is inhibited by use of anti-EGFR monoclonal antibodies like cetuximab, and that may lead to hypomagnesemia in these patients. Hypercalcemia in cancer patients pose to poor prognosis. This is due to two pathways. One is with the osteolytic release of the calcium into the circulation, and the other one is stimulation of osteoclasts. This most common in primary bone carcinomas, metastatic breast and prostate carcinomas. This hypercalcemia is most of the time rank ligand mediated through the parathormone, and the treatment is with volume expansion with saline, biphosphonates, and rank ligand inhibitors like denosumab. The biphosphonates like zoledronate may cause acute tubular necrosis. The palmitronate, another biphosphonate, which may cause collapsing variant of focal segmental glomerulosclerosis. Denosumab, like rank ligand inhibitors, are mostly used in biphosphonate resistant cases. Then hypophosphatemia. It is a consequence of chemotherapy drugs like ifosfamide, cisplatin, imatinib. It may be due to generalized malnutrition from anorexia in cancer patients, the renal phosphate wasting due to chemotherapy drugs, and then tumor-induced osteomalacia in carcinomas like giant cell tumors or osteoblastomas. The treatment is mostly replacement or surgical resection of tumor like osteoblastomas or giant cell tumors. Then metabolic acidosis is also common in malignancy, which may affect again the um, these patients. This anion gap acidosis and non-anion gap acidosis are most commonly found in cancer patients. The lactic acidosis is most cancer specific. It may develop due to tissue hypoxia from sepsis or cardiac failure. The anaerobic glycolysis by tumor cells, stimulation of lactate production by tumor-derived cytokines, and thiamine deficiency may lead to acidosis. The non-anion gap acidosis is contributed due to infection, therapy-related diarrhea, renal tubular acidosis, light chain associated tubular injury in multiple myeloma. So in nutshell, so there are multiple electrolyte abnormalities like hypernatremia, hypomagnesemia, hypokalemia, hyperphosphatemia, hypophosphatemia, due to decreased dietary intake with cancer-associated anorexia or tumor osteomalacia, causing fibroblast growth factor 23 secretion from hemangiopericytomas or giant cell tumors. And hypomagnesemia is the most common electrolyte abnormalities found in these patients due to omitting diarrhea, decreased dietary intake, decreased absorption, and chemotherapy drugs like cisplatin, EGFR inhibitors. uh, in hematological disorders and kidney diseases. The multiple myeloma is a pathological proliferation of terminally differentiated plasma cells. This is second most common hematological malignancy after non-Hodgkin's lymphoma. It consists of osteolysis of bone, suppression of normal hematopoiesis, overproduction of monoclonal immunoglobulins that deposit in organ tissues. The bone pain, the symptom like bone pain and fractures, anemia, infections, hypercalcemia, edema, heart failure, and renal disease. The kidney manifestations of multiple myeloma are like myeloma cast nephropathy, amyloidosis, then light chain disease, heavy chain deposition disease, immunotactoid glomerulopathy, fibrillary glomerulopathy, light chain Fanconi syndrome, plasma cell infiltration, cryoglobulinemia, membranoproliferative glomerulonephritis, and membranous glomerulonephritis. So this overproduction of this plasma, abnormal plasma cells, which leads to kappa and lambda light chains and heavy immunoglobulin chain production. This increased urine albumin secretion of more than 2 gram per day, causing glomerular deposition of light chains or monoclonal immunoglobulins, leading to glomerulopathy and proteinuria. This glomerulopathies of different um, um, this thing amyloidosis and monoclonal cryoglobulinemia that I'm not gonna discuss in detail at present. So, and another proximal tubulopathy may be because of endocytosis of light chains, leading to acute tubular injury and fibrosis. This endocytosis of light chains also leads to Fanconi syndrome with or without acute kidney injury. The cast nephropathy, this light chains bind with Tom horseball protein, forming insoluble casts that obstruct tubular lumen and elicit local inflammation, leading to acute kidney injury with or without chronic kidney disease. And this are cast form due to free light chains are deposited in the distal convoluted tubule and ascending limb of the loop of Henle. So management for this nephropathies, cast nephropathies and all, it's mainly depends on volume resuscitation, urinary alkalinization to decrease the cast formation. High dose dexamethasone has found to rapidly reduce these free light chains. The other drugs like thalidomide and lenalidomide are used in the multiple myeloma to control this free light chain deposition in the nephrons. The proteasome inhibitors like bortezomib, along with thalidomide and high-dose dexamethasone, is considered as renoprotective chemotherapy in multiple myeloma patients. Then hematopoietic stem cell transplantation is the treatment for the multiple myeloma. Then leukemia and lymphoma. This kidney manifestations are like tumor lysis syndrome, thrombotic microangiopathy, malignancy associated hypercalcemia, paraneoplastic glomerulopathies, urinary tract obstruction, parenchymal infiltration, leukostasis, lysozymuria. And these are The kidney manifestations in the hematological malignancies like lymphoma and leukemias. To summarize the hematological malignancies, the cast nephropathy is the most common cause of renal failure in patients with multiple myeloma. A rapid lowering of free light chains with renoprotective chemotherapy can reverse renal failure from cast nephropathy in majority of cases. Based on current evidence, the extracorporeal removal of free light chains with either therapeutic plasmapheresis or high cutoff hemodialysis is not recommended. Leukemia and lymphomatous infiltration of the kidneys is common on autopsy, although it is usually not clinically apparent. Enlarged kidneys on imaging and resolution of the acute kidney injury after therapy with systemic chemotherapy or radiation support the diagnosis of kidney infiltration by lymphoma or leukemias. Then moving towards the anti-cancer drugs induced kidney diseases. Various neoplastic drugs act on the kidneys, excreted through the kidneys, or may cause some depositions in the nephrons, causing various diseases relating to the acute kidney injury. So mitomycin C, gemcitabine, like anti-angiogenesis drugs, mainly acts on the afferent and efferent vasculatures of the glomerulus. In pamidronate, interferon, anti-angiogenesis drugs again act on the glomerulus. The platinums, ifosfamide, pemetrexed, zolentonic acids, they cause acute tubular injury. Tyrosine kinase inhibitors, BRAF inhibitors, and immune checkpoint inhibitors mainly act on collecting dust and cause tubulointerstitial diseases. So conventional agents like cytotoxic drugs, like platins, alkalitic agents like ifosfamide, then anti-tumor antibiotics, mitomycin C, then antimetabolites like methotrexate, pemetrexate, pentostatin, gemcitabine are the conventional agents causing renal injury at various parts. Then targeted agents like anti-angiogenesis drugs like uh, vascular endothelial growth factor, soluble receptors, or monoclonal antibodies, or tyrosine kinase inhibitors. Then EGFR inhibitors, BRAF inhibitors, and protease inhibitors. The immunotherapies include most interleukin 2 interferon, and then immune checkpoint inhibitors like anti anti-cytotoxic lymphocyte antigen 4 and chimeric antigen receptor T cells. The conventional chemotherapeutic agents like gemcitabine, mitomycin C, and cisplatin causes thrombotic microangiopathy. The pamidronate causes collapsing focal segmental glomerulosclerosis. And platins, ifosfamide, pemetrexed, zoledronate, they may cause toxic acute tubular injury or acute tubular nephron injury. The methotrexate leads to crystalline deposition in the kidney, causing acute tubular interstitial nephritis. And vascular endothelial growth factor inhibitors may cause focal segmental glomerulosclerosis, thrombotic microangiopathy. All inhibitors and BRAF inhibitors, they also cause pseudo-acute kidney injury, then acute tubular nephrosis, and acute interstitial nephritis. EGFR antibodies leads to hypomagnesemia. Cancer immunotherapy drugs like interleukin 2 may lead to prerenal acute kidney injury, acute tubular necrosis, and glomerulonephritis. Interferons cause thrombotic microangiopathy and focal segmental glomerulosclerosis. Immune checkpoint inhibitors may cause minimal change disease, acute interstitial nephritis, and transplant rejection. Chimeric antigen receptor T cells, that is CAR T cells, may lead to different electrolyte disorders, acute kidney injury, tumor lysis syndromes. So individual drugs with like platinum agents, they may cause direct tubular toxicity, and the prevention is volume expansion and magnesium repletion. The ifosfamide may lead to acute kidney injury due to acute tubular nephrosis, nephritis, and hemorrhagic cystitis, and nephrogenic diabetes insipidus, mainly due to direct tubular toxicity and bladder injury. And the prevention is volume expansion and a MESNA for hemorrhagic cystitis. The cyclophosphamide may cause hyponatremia and hemorrhagic cystitis due to ADH secretion, hemorrhagic cystitis due to bladder injury by the metabolite. Again, the treatment is a volume expansion and MESNA for hemorrhagic cystitis. And then gemcitabine may cause acute kidney injury plus hypertension and proteinuria. And the mechanism behind this is thrombotic microangiopathy. Drug withdrawal and complement inhibitors may be considered for acute kidney injury caused by gemcitabine. The targeted therapies like vascular endothelial growth inhibitors or multi-target tyrosine kinase inhibitors, this most of the time may cause hypertension, proteinuria, and acute kidney injury in cancer patients. And serial blood pressure monitoring and urea protein creatinine ratio monitoring is required in these therapies. So I'm briefing about the rationale of immunotherapy. This T cell are normally activated by two signals. That is antigen presenting cell displaying an antigen in the context of cell MSC molecule to a T cell with receptor specificity for that antigen. And the other way is binding of a co-stimulatory molecule, that is CD28, on the T cell to its cognate ligand on the antigen presenting cells. This negative regulatory checkpoints such as CTLA4 or PD1 on the T cell interfere with co-stimulation or binding to PD ligand 1 to inactivate the T cells. This monoclonal antibodies against PD1 or CTLA4 prevent this T cell energy against tumor cell antigen by preventing the inactivation of the T cells. The CAR T cell production begins with harvesting of T cells from the patient who is a candidate for CAR T therapy. These T cells are transfected with the vectors, generally viral, that genetically engineer the T cell to express a chimeric antigen receptor consisting of antigen binding domain, co-stimulatory domain, and CD3 chain domain. Thus, the critical steps of T cell activations are combined into one signal receptor that activates the CAR T for the effector mechanisms in the cancer patients. This CAR T CAR T cells recognize the tumor specific antigen that activates the CAR T effector mechanisms aimed at tumor control, including cytokine release, uh, tumor lysis, and macrophage activation. These mechanisms may occur simultaneously or independently of each other. The cytokines released by CAR T include interleukin 2, which allows expansion of CAR T cells in vivo, while interleukin 6 and interferon gamma have tumoricidal properties. This additional cytotoxicity of CAR T is mediated by perforin and enzyme B. This, depending on the scale of tumor cell death, tumor lysis syndrome may result. The tumor cell death also releases novel antigens that, if processed by antigen presenting cells like dendritic cells and macrophages, then can active new T cells. The activated T cells have their own effector mechanism of cytokine release. Thus, multiple pathways can converge to result in cytokine release syndrome, uh, causing a large systemic inflammatory cascade that is characterized by fever, hypertension, and other manifestation of severe inflammation. In such patients, they may require critical intensive monitoring and use of steroids and use of interleukin 6 inhibitors like tocilizumab uh, to treat the tumor uh, to cytokine release syndrome. This is all about the immunotherapy and targeted drugs causing acute kidney injury in the cancer patients. Thank you, sir.
Dr. Das, sir, your comment. Dr. Das, sir, your comment.
Yes. Sital, it was very elucidated lecture of yours. You have been burdened with so much information actually. So obviously, so vast information cannot be shared in a short span of time over 40 minutes time frame. So, but you have done nicely. I think it is a very good effort, Sital. Just I wanted to clarify certain points in your slides. One is,
Yes, sir.
Sital, can you tell me why alkalinization in tumor lysis syndrome was not nowadays advocated?
Sir, because alkalinization of the urine may cause again the like a cast deposition, may precipitate the cast deposition because of the increased pH of the urine, may again lead to decreased secretion of the cast.
Which cast you are talking about?
Like in methotrexate toxicity, sir, the
No,
cast formed by the methocystic crystals.
we are talking about tumor lysis syndrome, correct?
Yes, sir. Yes, sir.
So in tumor
In tumor
lysis,
lysis syndrome, there are increased calcium and phosphate complexes which may not get secreted into the urine, sir.
no, I don't think so. That is correct. One, you have said the alkalinizing the urine is basically done to make the uric acid to change over to urate form, which is much
Yes,
more
sir.
easier to excrete it out. That was the main purpose at that point of
Yes, sir.
time when we
Yes, sir.
initial thought process was there. So, but what has happened nowadays, it has
Mm.
been seen that hypocalcemia also is there, correct?
Yes, sir.
It is a
Yes, sir.
manifestation of tumor lysis syndrome.
Mm.
So, when you hypocalcemia, you have to remember that the calcium which is you are seeing is the total calcium value.
Yes, sir.
So, in the total calcium value, there will be two fractions. One is albumin bound fraction,
Yes, sir. And
other one is
free,
ionized
ionized.
fraction.
Yes, sir.
And in presence of metabolic acidosis or uh, whatever, due to the tumor cells degradation itself, there will be some amount of increased uric acid production, correct?
Yes, sir.
So, in that, you will see that there will be more of ionized fraction and the albumin bound fraction will be less.
Yes, sir.
Whereas when you alkalinize the blood, then what happens? The bound fraction will increase and the ionized
Mm.
fraction will reduce.
Yes, sir.
So that will cause tetany,
Mm.
hypocalcemic
More of
tetany.
hypocalcemia.
So that for fear of that, basically we are not over alkalinizing the patients.
Okay, sir.
Okay. The second point you have taken into account is forced diuresis.
Mm.
Okay, you have said that forced diuresis can be done, but nowadays it has to be carefully done. You cannot say that it has to be done at a 2 ml per kg per hour
Okay.
kind of thing,
Okay.
since most of the time the patients are longer. Basically, whenever you are
Hypovolemic.
treating a patient, you have to see what is the cardiac condition of the patient. When
Okay.
you are overloading the patient, if the urine output will not be adequate due to the tumor lysis itself, due to blockage, due to intratubular blockage itself, there can be chance that you will hydration will be counterproductive. And
Okay,
especially
sir.
so when the ejection fraction or the cardiac output is low. So that's why post diuresis, whenever we are talking about, you have to really look into it that whether there is a urine output is happening or not. And
Okay.
so it is not a one means one medication
One
fit
for
for
all.
all. Yeah.
Yes, sir. Yes, sir.
So it has to be
Understood, sir.
tailor-made.
Yes, sir.
Okay. So that is one point. Second one is high cutoff dialysis indication. You said that dialysis
Mm.
is not indicated. In certain situations,
Mm.
in multiple myeloma, we can offer high cutoff dialysis. Though that is
Okay.
basically when the patient presents with hyperviscosity syndrome.
Okay. Okay, sir.
If the patient is having hyperviscosity syndrome, you have to treat the patient as well as you have to reduce the free light chain or cast.
Mm.
Otherwise, it will cause more harm.
Yes, sir.
Okay, so in that
Okay.
scenario, otherwise, the we actually initial period high cutoff dialysis was have been given. All the trials were negative in the sense that we are not addressing the tumor burden. Basically, we are not treating the underlying condition. The production is more, and what we
Mm.
are removing is less.
Yes,
But
sir.
if you combine it together, probably it might give you
Help.
some better outcome. Those trials are not there right now, or I
Yes, sir.
am ignorant about that.
I have
Okay.
understood.
The last but one point is AKI is not benign. When we are talking about acute kidney injury in critical
Mm.
care setup, it is not always benign. Many times and many studies have already advocated that they have to be closely followed up, since there is a potential group of patients, subset of patients who progress to chronic kidney disease. So we have to find out those group of patients, and subsequently we have to address their issues. So
Yes, sir.
that is what the last but one. And then hyponatremia. You have nicely done justice about hyponatremia. And but major means minority of the fraction of hyponatremia, not minority, it is a
Mm.
significant amount, is due to the low intake of protein due to the ongoing uh, cancer which is there due to chemotherapy agents, due to sepsis, due to some other problems. The appetite decreases and that
Mm.
causes low protein intake. And whenever you have a low protein intake, urea is production is less, and
Mm.
especially so when the patient is having liver mets also, the urea production will be less. And the urea is a big factor in taking out free water from the
Water.
by the kidneys.
Yes, sir.
Okay, so that also is one cause of hyponatremia. So these things I have pointed out in your lecture.
Okay.
Wanted to discuss it. That's
Yes, sir.
all I think from my side.
Thank you, sir.
Otherwise, very good.
That's sir. Then I will discuss with you to have the specific points, particularly the chemotherapy drug-induced kidney issues, then some of the rare things which are not very super important for the critical care, but we should need to know, like post stem cell transplant, hematological malignancy that can happen in the sort of kidney transplant recipients, some sort of the other in particularly the monoclonal gammopathy related kidney diseases. So I think we will have certain now subdomain specific discussions, right? And where we will have both the critical care and nephrology colleagues coming, as well as the oncology colleagues coming, and we can have a tripartite discussion on certain. So we just wanted to give an overview. It is way beyond our capacity to actually absorb that. Shital did a very good job. But our intent was to give you an idea that this itself is a sort of huge speciality which is being developed, and with the advent of more and more advanced therapy for oncology, onco-nephrology is going to be one of the most, along with onco-critical care, the two most important support system for recovery of oncology patients. So we will come back on that. So we will again meet after one fortnight, and we'll come up with the topic, as well as I would request all of you who are attending regularly. I can see a lot of regular people. So you please do volunteer for presenting, because presentation is one of the best ways to also learn. And we have seniors like Dr. Dash, Dr. Rushi, Panditji, who can actually guide us to have a better understanding of the subject itself. So see you after 2 weeks, but next week we will have something on the critical care super specialty. We would announce it pretty soon. So good night and have a great weekend.
Thank you, sir.
Bye bye.
Thank
Bye,
you,
sir.
sir.